Well, welcome everybody to the 2014 Hamilton Symposium. I'm Dan Zismer, Professor and Director of the Graduate Programs in Healthcare Administration. On behalf of our faculty and our staff, welcome to all of you. The Hamilton Symposium honors the legacy of James A. Hamilton, the founder of the MHA program in 1946. Today we boast several thousand graduates who have served healthcare around the globe. The Hamilton Symposium is our opportunity to invite healthcare leaders, students, and practicing professionals to gather and learn as they move forward in service to their communities. Given that we are housed in the School of Public Health, we appreciate our mission to go beyond the basics of healthcare management in service to a broader mission of healthy communities. So again, welcome and thank you for taking your time to be here with us tonight. Before I turn the podium over to Javon Bey, I want to recognize some important people here this evening, our partners in this event, the American College of Healthcare Executives Minnesota chapter. They play an important role in our program. All our students are encouraged to become part of the ACHE. And at this point, I'd like to recognize the Minnesota chapter board members here this evening with us. Please stand and to be recognized. You're there, I know. And we thank you for your support in this evening's event. In advance of our introduction of our keynote speaker, I'd like to yield the podium to Javon Bey. Javon is a graduate of the MHA program. He is currently the CEO of Mercy Health System in Janesville, Wisconsin, which has an extraordinary reputation for being a leader in healthcare. He's also serving as the board chair of the MHA Alumni Association and Foundation. Javon will provide welcoming remarks prior to the introduction of our speaker. Javon, thanks for being here and welcome.
Thank you, Dan, and welcome. It's great to see so many healthcare leaders and faculty from across the healthcare industry here, and I had a chance to meet several of our students for the class of 16 that's just starting tonight, and you're going to have to really work hard, strive hard to try to become better than the class of 78, I can tell you that. It really has. There's been several things that have been recorded that the class of 78 is truly surpassed all other classes. Wade Miller's not here, is he? We were having a fight about that last night at the Hamilton Society. But I want to welcome all of you to this event. We're really pleased to have Steve Philly here. He's going to really give us an excellent presentation on Medicare and obviously group health. We're glad to have him, welcome him. He's a Michigan grad. Don't hold that against him. Michigan tries hard, and they're getting better. I mean, they really are. They're getting better. So welcome, Steve. It's great to have you. But on behalf of the Alumni Association, it is my privilege to serve as the current president of the Alumni Association. We just really want to continue to thank all of you for coming and recognizing the legacy of James Hamilton. Professor Hamilton is the founder in this field and really one of the great minds that started the whole concept of being able to take healthcare administration and make it into more of a business science. And I think it's Dr. Hamilton's words that I'd like to share. And he states, which have always struck me and has been at the core of my involvement in the Alumni Association. Dr. Hamilton said, "Alumni bonded in common skills, attitudes, and values would be a constant means of support for each other and the program." And that's truly what we want to be, is a constant means of support for each other, for the students, and for the MHA program. And so we recently, over the past year, actually merged our operations of the Alumni Association with the program. Dan is serving as our CEO, and I have really good feelings about bringing the two together after many, many decades. So tonight, on behalf of the MHA Alumni Association, one of the co-sponsors of this event, I'd like to welcome all of you, thank all of you for coming, and we're looking forward to an exciting program. Thank you.
Now we move to the centerpiece of our program this evening in the introduction of our keynote speaker. You know, occasionally along the way in a profession, you'll run into a handful of people, if you're lucky, who are considered to be not only good human beings and professionals at what they do. This man is both. Before I deliver his credentials as speaker for this evening, I want to emphasize the humanity of this man. We've known each other actually a very short time. Steve Nelson moved to Minneapolis to a new assignment at UnitedHealth Group about 2 years ago. And Steve reached out to me with an offer. And that offer was, I'm here. I would like to offer support of my organization and myself to your programs. And as I said, and I can assure you, I don't get a large number of those calls. So I think this is a testament to Steve and UnitedHealth Group and their service to our industry and certainly to our community. I'd like to provide you a little bit about his credentials and his resume before I invite him to the podium. Steve Nelson was named Chief Executive Officer of UnitedHealthcare Medicare and Retirement, a division of UnitedHealth Group, in March 2014. Serving nearly 1 in 5 Medicare beneficiaries, UnitedHealthcare Medicare and Retirement is the largest business dedicated to the health and well-being needs of seniors and other Medicare beneficiaries. UnitedHealthcare Medicare and Retirement would rank as the 62nd largest company on the Fortune 500 if it were a standalone organization today. Prior to his current role, Steve served as Chief Executive Officer of UnitedHealthcare's Community and State Business, an organization that delivers solutions to 25 state governments and over 4 million individuals, including more than 2 million children. Prior to joining Community and State, Steve served as the Chief Executive Officer of UnitedHealthcare's employer and individual West region for 4 years. In this role, Steve was responsible for commercial health plan operations for 5 million members in Alaska, Arizona, California, Colorado, Hawaii, New Mexico, Nevada, Oregon, or Oregon, as they like to say, Utah, and Washington. Previous to his role in the West region, Steve was president of UnitedHealthcare Community and State. He served as president of both the Eastern region and senior products division of HealthNet and held various executive roles in Henry Ford Health System in Detroit, Michigan prior to that. We also like to welcome Steve's wife, Carrie, this evening, and thank you for taking your time to spend it with us. So, with that, I'd like to welcome Steve Nelson to the podium, and thanks for taking your time with us this evening, Steve.
Well, thank you, Dan. I appreciate that kind and kind of long introduction. So I've got to work on that. I have to stop moving around, I think is what occurred to me as I was hearing that. So yes, I am from University of Michigan, and so we should get this over with right now. There's a lot of, I know there's this whole thing about, you know, who's number one, and it goes back and forth, and there's, you know, I think some healthy competition, right? Healthy competition. And so, you know, it's just a couple things. So I moved here about 2 years ago I moved to Minneapolis from Laguna Beach, California. And I didn't lose a bet. It was actually something I wanted to do, although last winter, anybody who lives around here was absolutely brutal. So we were definitely having second thoughts last winter, but a couple things threw me off. One is everywhere I go, there's this reference to the U of M. Very confusing to me. So I quickly figured out that U of M, two U of M's, there's a lot of commonality, both cold places. Now there are some differences though, and that we have differences, our mascots. I'm just going to point this out. Wolverines, Gophers. I mean, I don't understand that. I think you guys should work on that if you really want to be number one. I also took the liberty of looking up our football records. Just, I didn't know what I would find for sure, but in the last 30 years, Michigan has beaten Minnesota 27 times. And so I can't, I don't really know what happened this year, but I like to be a long-term thinker, so that's, and use statistics to my advantage, but as we do. But anyway, hey, I think this is a very impressive program, all kidding aside, and really honored to be here. In fact, when I first moved here, as Dan mentioned, I said, hey, you know what kind of engagement do we have with the University of Minnesota? It's highly regarded. I know a lot of people, a lot of associates, and met a lot of people in my career that have graduated from University of Minnesota. MHA program had a really high regard for these folks, and I know that they attract some high caliber young people, and we ought to be really closely associated with them. So immediately we started increasing our engagement with the program, and now I think in the last couple of years have hired a few folks from your program, and they're doing great and really impressed. And I continue to be impressed, and so it is really, in all seriousness, an honor to be here. But as a token of goodwill, I am going to speak slow and use small words. I'm just kidding. Yeah, so this could go on for a while, so I'll get into the topic. Let's make sure this works here. All right, great. What I really want to talk about is thinking differently tonight, and I hope that you've all come with an idea about thinking differently. I think we are in an industry that, if nothing else, requires us to think differently. And if I could, I'm going to go back 30 years for me, when I was sitting in my very first year of my graduate program at the University of Michigan. And so it was 29 years in 1985. And what I remember about that first year was there was a lot of topics that were kind of new to me. I came out of the arts and sciences undergrad, and I had some idea about healthcare, but not a lot. I knew it was something that I was interested in. Obviously, but there's a lot of terms that were new to me. One was population health, this idea of population health. And it was talked about a lot, like it was a really powerful idea, and this was kind of the new thing. Talked a lot about systems, and that this was a powerful concept, whether it was a vertically integrated system. There was a lot of debate between not-for-profit systems and for-profit systems. You remember the 80s? There was a lot of talk about that. And what I think is interesting is fast forward 29 years to today. If you Google right now, population health, it'll come up, and there'll be a lot of references to this as an emerging idea, as a relatively new concept, one that is sort of making its way and gaining traction. And I find that kind of interesting, that a concept that I heard about in graduate school roughly 30 years ago is still being talked about as new ideas. The idea of our United States of America healthcare system becoming an actual system, and this idea of taking care of populations. And the fact that we really today, 29 years later, don't operate as a system and really are still struggling with the idea of populations and taking care of them, I think is interesting and somewhat frustrating to me, actually, as a person who has spent my life thinking about healthcare and how do we improve this system in our great country. And so I want to talk a little bit about that, and I'm sure there's different opinions. Dan said that I could be provocative, so I'm going to be provocative, and hope that we can have a great discussion at the end of my comments. So the idea is, clearly, we need different thinking. We cannot solve the problems and the kind of unique challenges we face with the same thinking that created them. Now, why are we struggling, or why are we sitting here 29 years later with kind of a bit of a mixed message about how our system is performing? One, and I'm just going to offer a few ideas. One is there is not good transparency about the healthcare system, and part of that is because it is just hard to get data. It has been hard traditionally, and there is a lot of forces that are kind of working against what I would say free market forces, and there's some pockets of good, fair competition, and there's other parts that are highly regulated, and then there's this whole idea of who shares data with who, and there's a lot of barriers to that. It has been traditionally. And I think that has hurt our ability to operate as a system and to make progress. Second, there has been generally a lack of connectivity. And what I mean by that is, for a long time, it was really challenging to connect payers, hospitals, providers, connect with consumers of healthcare. Very challenging until, I would say, actually fairly recently. Also, this idea of population. Who is the population that we're serving? And I offer, as an example, if I go and talk with one of our hospital partners, typically they will define their population as a geography or some kind of a market share of the kind of catchment area that they sit in the middle of. When I think about a population, I sometimes will think about it as a demographic, as folks who are funded by Medicare or funded by state government or funded by an employer group, national employers, small group employers. And it's interesting because, so if you can't agree on populations, then you're also going to, I think, stumble on your way to taking care of populations and improving the health of a certain population. And then last, I think generally there's been a lack of partnerships. And I can say this, I think, pretty candidly because I spent half of my career on the not-for-profit delivery side with the Henry Ford Health System in Detroit and half on the for-profit payer side. And so I've been in both worlds, and I can tell you from both sides, there has been I would say some animosity because of just the incentives and how they're aligned. And our interactions have been highly contractual and not highly based on sort of shared incentives and taking care of the same population. And I'm being general here. And this is, I think, kind of what's been going on over the past 30 years. And so I think that leaves us in a place where we've had some challenges. And I would say we are not operating as a system to a large extent. And we have not done a great job of taking care of populations. Now, clearly there are pockets of good stories. And there's evidence of progress. But I think we are clearly not at our potential. And I think there's a lot of upside in what we do and what we all care about and in the careers that we've invested in and the industry where we have spent a lot of time. So I do think things have changed, though. I think they have changed in several areas. One is we are connected now, and there is transparency. We do have better collaboration. There is personal connectivity, and I'm going to talk a little bit about that in a minute. And I think we have a new kind of leader that is emerging in healthcare, and I think we need more of that. But I think there is. It's not to be. I don't want this to be a depressing conversation. I think there is a lot of upside and a lot of hope for solutions. And let me just give you an example that we have had some experience with in UnitedHealthcare. And I don't know if you can, I hope you can see better than I can, but since I have this memorized, I don't need to read it. But what is going, this describes a new model of care and an approach to taking care of a population. And this is in our Medicaid business, and we call it the patient-centered care model. And all the way, I'm going to start at the right, on the far right, the circle. And basically the approach and the idea is that we want to take care of a person, and we want to take care of the whole person. So we want to take care of their physical health, their social health, and their mental health. And we think that if you leave one of those pieces of the pie out, then you're going to miss a great opportunity to improve their health. And particularly in the Medicaid population, where housing and nutrition is just as important as do they have access to a hospital or to a PCP. And so what we've done is we've gone out to communities and we've built, in some cases, what we would call virtual ACOs, where we don't actually have to have a contractual relationship with these network of providers, but we connect them through data and technology, and we connect them through someone who we call the caregiver coach that we drop in the middle of, and we drop in Mini in the middle of this virtual ACO that we build in the community. And it doesn't just include hospitals, physicians, but it also includes alternatives to housing. It includes social workers, includes transportation, it includes mental health providers, and a variety of other kinds of community-based resources, in addition to the typical, what you would call health plan kind of network of hospitals and providers. And so we have found this to be really powerful. In fact, in Florida, we have hundreds of what we call community health workers that we have hired to help people navigate the system and to help build these networks of community-based resources in addition to the networks that we typically contract with. Now, the question is, how do you get them into this model of care? And we have found that about 1.4% of our Medicaid population actually generates about 35 or so, or about 35% of the costs that we actually see coming into the system. About 5% of the folks generate almost 50% of the costs. And we typically refer to them as super utilizers. And these are folks that in some cases have visited the ER, over 50 times in a year. So they're literally going to the hospital and the ER almost every week. And that is generating not only bad outcomes, but high costs. And so identifying them kind of early on in the process is our priority, and then getting them quickly into the system of care that we call the patient-centered care model. And how we do that is by utilizing some of the things that I talked about that we've been missing in the past: technology and data and relationships with caregivers. So for example, the top left quadrant here that has a map of the United States, and those represent the states where we provide Medicaid beneficiaries health coverage. And I can literally go into any state on my iPad, and I can click on a community, and I can have a drop-down menu that allows me to choose ER utilization, PCP assignments. I can go by disease category. I can go by age. I can go by moms, kids. I can go by chronic, folks that have more than one chronic condition. And I can find out where they are and their actual utilization patterns. And I've actually had this conversation with governors sometimes when they're trying to figure out where to invest in public health in their states. And we can actually drive their policy decisions based on the data that we have. In the case of like Nevada, for example, where we cover through either a Medicare, a Medicaid, or a commercial kind of a coverage, we cover almost 50% of everyone that lives in Nevada. And so we have unbelievable data-rich information about how folks use healthcare and how they don't use healthcare. And we can have that conversation with policymakers and help them make better decisions. In Nevada, Anyone here from Nevada? No one from Nevada. What's that? You used to work there? Okay. So they have sort of an interesting mental health challenge, actually, because there's some barriers to get into Nevada if you're a mental health provider or behavioral health facility. And they, not surprisingly, have really sort of wacky behavioral health costs and utilization because of their design. And we can help. I was having this conversation with some folks in the governor's office in Nevada, where they have actually changed the way that they're thinking about their policy in mental health and behavioral health in the state of Nevada. And we can influence those. And we can go find people that are in this high utilization category through this kind of a data search. We can also go into our clinicians and our hospitals that we work with closely and identify folks that have had high utilization and special kinds of conditions, and we can help. And we actually go into the physician's offices and counsel and consult with them on how we can best navigate with this person, literally holding their hand through the healthcare system, and actually help their primary care provider and be an extender of that. We also share data with the PCP. So when someone is being discharged from the hospital, they have an actual real-time data source and a reminder that helps them to know that, and that creates that connection. We can also go actually into neighborhoods through different community centers and other kinds of places where we can find folks who are really struggling, either in the housing shelters or other kinds of places where we can find folks that are our members that we know about, but are misusing the system, and connect them with one of our caregivers and then get them into the system. And so this has become a really powerful model. And just to give you kind of an insight into what it's producing so far, it increases the primary care visits for these folks 21%. We've reduced admissions in this population by 30%, which if you're running a hospital, that might be bad news to you. But we've also reduced ER visits, which means when they do go to the hospital, they're going there for the right reason. And this takes 200 to 500 basis points of costs out of the system for this population. And I can just tell you, on our Medicaid business at UnitedHealthcare, we spend about $20 billion a year on healthcare, on claims costs, actually. And so you take, in this case, across a whole population, 70 to 170 basis points out of that, you've taken a couple $1 billion of costs out of this system. And you have, along the way, improved the quality of their life and improved their health care. And so this is how we think about population health, and it can't be done without really strong partnerships with the community and with caregivers of all kinds. And so going back to this idea of what's changed, and taking the example that I just mentioned, there are many other examples, and I'm sure you guys are very familiar with other examples in your own organizations where we are breaking barriers to technology, connectivity, the relationships that we have, and also in leadership. To give another example about personal connectivity, it turns out that, and many of you might already know this, but almost 50% of babies that are born in the United States are born into a Medicaid family. So that's the first time I heard that, I was actually really surprised by that. I didn't realize that statistic was so high. And it turns out that, as in our definition, anyway, just how we think about it is when a woman becomes pregnant who is also a teenager, we think about that person as a high-risk pregnancy, even though they're perfectly healthy. But the chances of them being in a stable environment where they're actually getting good prenatal care we find that to be statistically low anyway. And so if we can connect with them and help them get the care they need in a prenatal setting in a regular way, we know that that'll produce better health and life for the mom and for their child over the life of the child, right? And so what we've done is we've created this program we call Baby Blocks. And once we identify that they've been pregnant, we can tell because of our sort of data engines. We reach out to them via social media or text messaging. And assuming we can connect with them, which we do in most cases, but because moms have smartphones, even if they're on Medicaid, we can connect with them and we help them to remember their course of treatment, to encourage them to go visit their OBGYN, to take their prenatal vitamins and so on and so forth. And if they do that, we offer them Old Navy gift cards, for example, or some other kind of incentive. That creates this change of behavior that creates a whole different dynamic for them. And in fact, in the cases where we've done this, in Wisconsin, we did a big study here on this population, and the folks the moms who engaged in this program called Baby Blocks, we actually reduced preterm births by 30%. A dramatic result for a very simple thing, but it's all because of using sort of modern technology and some incentives and education. And so powerful, powerful ideas. And so the world is changing, and these opportunities are in front of us, and I'm really excited about using all these in a way that I think does go after a true population health kind of a model and does get to the idea where we can actually act more as a system in our country. So what will it take? We're going to offer 4 ideas and just talk a little bit about them, and interested in your thoughts about them as we get into the Q&A session. First, I think we need to blur the lines. And I think we actually have an opportunity to, and what I mean by that is the idea of who's the provider, who's the payer, who's in charge of the patient, those lines are getting blurry. And I was talking to a friend of mine who runs the Stanford Health System out in California, and he was just kind of giving me an update on what they're doing there. And he said, I do need to tell you, I just want to be straight up with you, we're starting a Medicare Advantage health plan. And I said, that's great. I mean, it's, it doesn't come at me as competition. It comes at me as the lines are getting blurred. And I think that is powerful. I think that's what needs to happen. I think the lines between where does caregiving start and where does financing end, and sort of that whole dynamic needs to change dramatically. And I think the lines need to get blurred. And unless lines get blurred, we will not be able to operate as a system. And I think that in a lot of cases, this starts in the graduate program. I think that I was talking to Dan and John before this, and I was at University of Michigan a couple weeks ago talking with a group of folks that were trying to think about the future of the Michigan graduate program in healthcare, and what kind of leaders should we be training. It was interesting that I'm on this advisory board that's helping the dean and the faculty think about this, and it's me and like 8 hospital CEOs, basically. And they are all saying, I tell these kids that if you're thinking the only job for you as a hospital CEO, you're missing a huge opportunity. There's this huge opportunity out in healthcare that is going beyond the acute setting. And it was interesting because I think, to be honest with you, the faculty are kind of struggling with that as well. How do we kind of make this shift to this very dramatic changing industry, and how these lines are getting definitely blurred? And I think people like me who have spent time on both sides or in different segments of the industry are becoming more common. And I think the next generation of leaders will definitely be part of that, and the lines will get blurred because how we think about the industry. In fact, as I think about the future of the person who runs one of our markets across America, probably will come from tech with a good understanding of healthcare, as opposed to healthcare that we try to teach them tech. And so it's sort of an interesting thing that's happening. So the lines are getting blurred. Second, becoming a system. The only way that we become a system is that we work together differently. And this idea of collaboration has been a popular topic for a long time, but we need to figure this out. And I would say, look, as somebody who's works for a big managed care organization, payer organization, we have created barriers to that for sure. And I think that, you know, on the delivery side when I was there, we were putting up walls all the time as well. And so we've got to figure that out. And I think one of the ways is to dramatically change our incentives and how we think about sharing the financial stewardship for the patients and the populations that we serve. And if we can, I think, break through that conversation, I think powerful change will come. And so we are spending a lot of time focusing on this idea of how do we change those incentives and how do we make when we receive money from a state agency, an employer group, or the federal government, how do we distribute that in a way that produces the best outcome and the best healthcare, the best evidence-based medicine experience that money can buy. And so sometimes that comes out as a antagonistic contract negotiation, but we've got to change that dynamic, and I hope that we can. And I see a lot of evidence out there, pockets all across the country where that dynamic is changing. And then last, we've talked a little bit about leadership, but I really do believe at the end of the day, leadership is the secret sauce. It is the thing that will change this. And I think honestly, it is the only thing that will change it. I had the opportunity a few weeks ago to listen to this guy named Gene Kranz, who you may recognize his name, but he's the guy that was in charge of the ground crew for the Apollo 13 moon mission that, of course, failed. And failed in the sense they didn't reach the moon, but they did get the crew back safely, if any of you were alive then or watched the movie. But they did get back safely, and it was interesting. He wrote a book called Failure is Not an Option. And there was just a paragraph that I was stuck on that he talked about. He said, at the end of the day, technology failed us. But we had something stronger than technology, and I'm paraphrasing here. He said, we had a collective group of people who have amassed years and years of experience, and they had as their motto, failure is not an option. And that created this dynamic that allowed them to do a very improbable thing and get these 3 astronauts home. And this was, of course, in the 60s, but it still is a powerful message. And to hear him tell the story and how they kind of took a sort of impossible situation and got those astronauts home is pretty inspirational. Actually, to hear it in his own words was more inspirational than the movie, if you can imagine that. The movie was pretty good. So I think the leadership is a big deal, and how we train them and how we think about it ourselves as leaders, I think is really powerful. And I put clinicians on there because I actually believe that without and anyone here a physician? Okay, great. So talking to you here. I think unless we get collectively inside the graduate medical education system, then we won't have the breakthrough that we need. And there are barriers there, you know, to try to break through there and to try to help our future clinicians think differently about the system and be open-minded to new kinds of incentive models to actually incentivize you to practice evidence-based medicine and to make the pivot from volume to outcomes. And I know that that's why physicians go into training, and so I'm not doubting the motives, but it is easy to get stuck on the incentives that produce an income for you to take care of your families. And so I know that's a tough position to be in. And so we need, as an industry, to help figure that out and sort of push the envelope there. At the end of the day, I believe we need to get comfortable with being uncomfortable. And a lot of these topics touch on some sort of sensitive nerves, I know, but it is the only way that we're going to have a breakthrough. And this is coming from somebody who has really spent, the last 25 years or so thinking about this, working hard on it, and I love our opportunities. I think that our system has the highest potential of all the systems in the world. And I have studied other systems in other countries. I know there's a lot of talk about different ways to do this. There's a lot of different political views, even inside our country, about how this should happen and the role of the government. However it plays out, there will always be a need for people who can think differently and can think beyond lines and boundaries and can think in blurred lines and are comfortable with being uncomfortable. Now, I'm just going to ask you, if you could, to think about my little story about 29 years ago and kind of the world at that time and how I was hearing about concepts like population health and vertically integrated systems and things like that. 30 years from now, I hope I'm still kicking around, and I hope that I can say, wow, we figured this out. 30 years from now, but it's interesting though, right now, sitting here today, I think about some of the barriers we have in front of us to really actually act as a system and get healthcare costs under control, improve the quality of care and our health status as a country and our outcomes. There are a lot of barriers. But you think about sort of 30 years and what could happen in those 30 years. So, as just for fun, I thought about some things that have sort of, when I was sitting in the classroom 30 years ago and I was dreaming about my role in the healthcare system, things that I didn't see coming that are kind of, I think, exciting and interesting. You can buy a 3D printer and you can print a hammer, or you can print a screwdriver. You guys know this, right? I mean, this is, and so now they're using this in space. Instead of having to bring tools, if they're missing something, you can actually send up to a 3D printer tools. They don't have to ship anymore. Imagine if the Apollo 13 astronauts had access to a 3D printer. They would have solved their problem. Pretty incredible. I didn't see the Tesla coming. Now, the Tesla is sort of this interesting, they're totally changing the way that we think about automobiles. Does anybody have a Tesla here? Someone? Okay, so I don't have one either, but I have a couple friends who have them, and they talk about this experience like it's basically whenever they have a problem with their car, they just call someone and they upload a new software to their car and it's fixed. No one comes, they don't have to do anything. It's just like getting the 8.2 whatever version on your iPhone. It's exactly like that. So you got to change the tires, and that's about it. It's crazy. Really, I didn't see that coming. The way that mobile has affected our personal worlds, and think about the iPhone becoming this one platform to do so many different things. It's not actually about the iPhone, but just this idea of a mobile technology, one single platform to do so many different things. Did not see that coming. This whole craze and movement towards health and wellness that our country has undergone, and this sensitivity to, I mean, look, we still have a problem. 20% of us still smoke, 30% of us are obese, yes. But there is an attention and an effort and a popularity with health and wellness that it's its own industry category, and it is one of the fastest growing categories in healthcare. Netflix. I have 4 adult children. None of them have cable or satellite. They all use Netflix and stream everything else. You know, I actually have DirecTV because I haven't made that leap yet. But it is changing the way that we think about not only media entertainment, but a lot of other things. Amazon, didn't see that coming. Drones, didn't see those coming. E-cigarettes and Red Bull, I didn't see those coming. And I certainly didn't see 30 years ago, sitting at the University of Michigan, the Minnesota Gophers beating the Wolverines and being ranked like, what are you guys, top 20? No, top 20 in football, right? It's a good year for you guys. Didn't see that one coming. So I think there's a lot of opportunity when you think about these kinds of things and where we could be in healthcare. And I know you're all working and dreaming on about these same things. Look forward to your questions and appreciate the time. Thanks.